Okay, so welcome everybody. As Kurt mentioned, you get to listen to me talk today. We're talking about just addiction screening and treatment basics. So you have a person, how do you screen to see whether they have some type of a use disorder? And then what happens after that? So you might identify something or identify a high risk, but then what? I think that's always one thing that it's sometimes I think primary care, it's that naive is, ignorance is bliss in a way. Like, if you don't screen, you don't know. You don't have to know what to do next, potentially. So this kind of takes some of that away. It'll give you the what do you do next? So quick announcements. These are recorded. As y'all know, you got the pop-up. Yes, there's free CME. You cannot sit right on top of me, honey. Attendance, please let us know who's in your room. Chat us in if there's multiple people. Rename yourself. You're all pretty good at that. Videos would be super awesome. All right, case presentations. If anybody has a case, I know Jane did one a couple weeks ago. It was fabulous on the person from the assisted living nursing home with the significantly exciting med list and chronic pain / use disorder issues. So any kind of case, it's always great to talk through, learn from, regardless on the level of what some of us might consider more simple to the most complex you can come up with. It's always good learning. Coming up in 2 weeks, looking at MOUD treatment options. So, we're going to look a little bit more in depth at the Suboxone, the buprenorphine products. We will talk about naltrexone as well as methadone, although to be able to do methadone for addiction, obviously you need to be in a specialized location, but we will talk about that. And then kind of getting more into the bread and butter of what do you actually do? You have a patient, and what do you do with that first patient besides, to get started? How do you start the med? If anyone did it wrong, the first patient, it was us. Admitted the first patient we ever did to the ICU, healthiest ICU patient ever, but that's how we all learn. Upcoming Wednesday talks tomorrow, Dr. Cole Peringer, who's one of the addiction fellows in the Twin Cities, is going to be doing his second part on negative consequences of antidepressants. The first one he is starting with is bupropion, Wellbutrin. I was just blown away last week by even the SSRI. So we're going to talk about those and tricyclics. Tomorrow is on the talk. Next week, I know I'm taking a long time to do this, but DHS is talking about the report cards and the final kind of statements on the prescribing report cards and what's happening with that. Charlie Resnikoff's coming back to talk about fentanyl test strips, and then contingency management, one topic that is hard to do but worth it, from one of our super awesome friends in Alaska. Addiction Connection, today's topic that went out was on gambling addiction, which is the only behavioral addiction that currently exists, although many things are being studied and should be, but gambling is definitely in there. And if anybody has any questions as you're getting started with your first patients, you want to talk about opioid stewardship, tapering, anything, please let us know. There's our phone numbers, our email addresses are at the end. We are here to help no matter what. Skipping the objectives, they're there for CME purposes. So what is the definition of screening? If we're going to say, okay, we need to start screening patients for all these things, in primary care, we know about screening mammograms, screening for breast cancer, screening for cervical cancer, those kind of things. So what is screening? It's, in the general sense of the word, it's kind of taking a general population to assess suitability for something. You screen applicants for a job to see who'd be best suited for the job. We're talking medical is you're screening a general population looking for some type of a high risk, high probability of having a disease like we just talked about. Typically, these are hopefully more inexpensive tests. And then what do you do about the treatment? Obviously, there's a lot of give and take in all the time in medical world. Prostate exams, PSA tests, that's a big one. Like, how often should you do them? Addiction is no different. But the reality is screening tests are not perfect. There's advantages and disadvantages to all sorts of screening tests, and you need to balance that. Like, what are you going to benefit? It's the whole thing I learned from Nancy Baker back in medical school is don't do a test you're not going to do anything about, but you want to make sure you're doing the test so you can do something about it for the patient's benefit. So when we're talking about addiction, people always, and have for years asked this, well, what do you all use in primary care? What do you all use to screen for patients in a general population? Primary care, especially if you're rural, but really anywhere, there's such a shortage. And so you're busy. So to throw yet another screening tool, to throw another thing, you want it to be simple, but again, it's scary because what do you do with it? And you want it to actually mean something. I can tell you that the screening tool we used early on in our program years ago is not even on our list of tools I'm going to talk about today, because it's over the last, I don't know, 7 years has dropped in favor because it's less valid. It's kind of played out. And so we're going to kind of look at the big ones, but you want it to be easy. You want it to be patient friendly. I think talking about something like addiction, as we talk about all the time when we're talking about stigma, is you don't want to ostracize patients either by saying, okay, we're going to screen you for, drug use disorder or alcohol use disorder. People might be really taken aback by that. So you have to do it in a way that it's going to be, calm to the patient. It's going to be welcoming to the patient. You want to be that safe place, in that same kind of atmosphere of, I'm here to help you, not judge you. And of course, there's a lot of reasons patients might not want to be very forthcoming. This is just so y'all have it in a pretty color-coded. Did this on an airplane, so I got really into the colors. This is the ones we're just going to kind of quickly talk about. Some of them are much better with certain substances, as you can see, as the DAST doesn't touch on alcohol. Some of them are better for certain ages, and some of them are patient administered or self-administered. Yes. Okay, so we're going to break them down. NIDA screening tools. The order in which I put these in this talk does not mean this is the best one down to the worst one. The tools that I have thrown into this talk at the beginning here are equally as good. I will throw up validity, the sensitivity and specificity as well in here. And so it really just is a matter of making whatever tool you're going to use work for your situation and your clinic, everything that was on that previous slide. So the NIDA quick screen is just a couple questions. In the past year, how often have you used the following? Alcohol, tobacco, prescription drugs for non-medical, and then illegal or illicit drugs. What it stands for, the NIDA quick screen, is National Institute on Drug Abuse is what NIDA stands for. If there's any affirmatives to this, so never, once or twice, monthly, weekly, daily, or almost daily are the answers to these. Where you kind of call it an affirmative is once you're getting into that monthly for most things. Once or twice would be more your illegals. Tobacco products is kind of where you're in that daily, and it's how much. So this one doesn't really give you great cutoffs as to what you call an affirmative, which is why I put this in beautiful quotes. So if any of them are affirmative, is where you'd have those further conversations. That's that SBIRT, considering a brief intervention. Are you smoking every day? Okay, do you have any desire to quit? That's your motivational interviewing type thing. If there's more, then you proceed to the NM assist, which is just the modified NIDA screen, which is right here. So what assist stands for is the alcohol screening or alcohol smoking substance involvement screening test. So this was modified from the original assist, which was a World Health Organization tool. And so it really helps guide clinicians. So you do this, typically it's on some type of an electronic format. And so based on how patients answer their answers to all these questions, that looks like the last page, it actually calculates it for you. It generates a score for you. It identifies what would be considered high or low risk, so there's less gray zone. It does give you a recommended level of intervention. Like, is this a person you should just continue to have those conversations with in your clinic? Is this a person you might want to consider the steps we're going to get to at the end of this talk, more of an inpatient situation? And it gives you kind of the resources to hear some discussion points. Here's some handouts you could give to your patient. This one, I believe there is a fee though, since it is done online and it's also comprehensive. And it really kind of directs you. The 5 A's is something we all learned about a million years ago. These are just what they are, which is why I kind of put them on here. But this is a very well used screening, especially when you're talking about scientific studies and research projects often use this screening tool. So the 8 questions, these are the 8 questions. I'm not going to go through them all, but you can kind of see it goes through the specifics. When I put in parentheses here, JC, mommy has to talk. You're going to have to wait. Sorry about that, everybody. So this is urge to use specific drugs. So it actually breaks it down. Like, have you had the urge to drink alcohol? Have you had the urge to use methamphetamines? Have you had the urge to? So that's kind of what this means. I just didn't really want to type it out. Obviously, the ever, when you're talking about very specifics, kind of higher risk immediately. Sensitivity, I love this. It's like the most broad range of sensitivity ever. A lot of this just depends on the substance. Specificity is pretty darn good. So the sensitivity, it's not that great at ruling out things, but just definitely a screening tool that is very widely used. TAPS. So TAP stands for tobacco, alcohol, prescription medication, and other substance use. So it also gives a brief assessment if they do screen positive. It's very brief. There's 4 questions, very specific to the actual thing. And then if they have a non-negative response, so if they say yes to anything, it automatically continues to progress. People like this because it's free and it's very similar to the assist. Patients can do this on their own, or they can be administered by a clinician. So this would be a situation, you just don't have the time. So it's a physical, and they fill out the 400 other pages. You just kind of throw that in there. I think at our clinic they have the cage and physical forms right now, which we'll get to. The problem with some of these, I'm just going to go on a little tangent. I always, of course, doing what I do, prefer to do this myself, to do screening conversations myself, even if I'm not using a specific tool, because you can kind of read patients better. You have that, more open communication. It seems that you're more accepting and you're more comfortable having these discussions. Obviously, if you're the one that's asking the questions, they're not feeling judged, like, oh my God, I'm going to circle this and then they're going to send me to treatment or call and turn me in without even having a conversation. But it's still, screening tools can be used in multiple ways. So the scoring on TAPS, high priority for people who put 2 or more. Now, what is the cutoff at 0, 1, and 2? Well, you can see 0, no use in the past 3 months. A score of 1 and a score of 2, that's not very well defined. So that, again, is hard. It's going to take a little bit of subjective, is what do you consider problem use or higher risk? So not the greatest, but not a bad screening tool. CRAFT, this is adolescents. I'll explain what the actual acronym is on the next page. This is your adolescent. This is pretty much the gold standard. Everything board related for us in addiction boards was CRAFT related. It's only 6 questions. It is designed to flag in high risk patients. You can see the sensitivity and specificity are actually really good. And so the CRAFT itself, have you ever gotten in a car with someone using? Have you used alcohol or drugs to relax? Have you ever used them alone? Do people worry about you? And have you ever been in trouble? They've added this quick question in here, which is why they call it the 2.0. In the last 12 months, have you drank more than a few sips? So this would be more your younger adolescents, because it's that gray zone with 18-year-olds. Any marijuana or synthetic products or anything to get high. So even like huffing could be considered. So any affirmative to this quick question, they call it, even though it's 3 questions, definitely warrants a longer discussion. But I always think CRAFT is actually, for some reason, one of those acronyms that's pretty easy to remember. So adolescent screening, I would say just go with this one. DAST, drug alcohol screening test. There's a couple different versions of this. There's a 2-question one, there's a 10-question one, there's a 20-question one. 10-question one is the pretty much standard that people use. The next slide, I'll show you what the 2 question is. Can do be done by the patient themselves or the clinician. It's all yes or no. The problem with the DAS is it's really only looking at drug abuse. So this is not good for alcohol or tobacco. So you do miss a lot, but it really can highlight, especially if it's a person you're very concerned about other drug use. One place where, when I was doing some more research, they like this test is in a person who is in recovery from having alcohol use disorder, a person who has been in long-term recovery, a person, I don't want to say that you trust, because I hate that word in a situation like this, but it's a person who, because they've had an alcohol use disorder, are at higher risk of having another use disorder. So this is kind of where they recommended it. Validity, it's not the greatest, but it's definitely decent, especially when we're looking at the 2-item question. So the 2 items are the starred ones here at the top. Have you ever used them for a purpose other than medical purposes, as we'd all understand? So a person who's getting a controlled substance and taking their pain med to help them sleep is a good one. Do you abuse more than one drug at a time? I mean, this would have to have a very forthcoming patient. And then if you look at the rest of the questions, this is basically your DSM-10 criteria, just in straightforward couple question, couple word things. Cage is also one that's probably been around the longest. The aid got added because it actually goes into drugs now. When Cage was originally developed, it was just for alcohol. We'll go into the questions in a second. Any yes warrants further questioning. So it's pretty simple. So have you ever felt the need to cut down? People are annoyed. Have you felt guilty? And then the need for an eye opener. So the aid just basically takes the alcohol and turns it into drugs. So you have to just say, have you ever felt the need to cut down if you're drinking? Have you ever felt the need to cut down on using other substances? 2 positives, pretty decent sensitivity and specificity, but any amount of yes anywhere in here should be a discussion. Might not be super, super high risk, but it's definitely a discussion, because if they're acknowledging any of these, it's definitely something you want to at least have that conversation with. And then the 5 Ps. After the 5 Ps, before I go into the next section after going through the screening, I think we could pause if there are questions on these. I always think these, again, for the millionth time, are just always so complicated. 5 Ps, there's a lot of pregnancy tools. The reason I chose to highlight the 5 Ps is the Maternal Morbidity Committee I sit on, the MOST-R committee, which is also a high-risk pregnancy committee I sit on, Dr. Cresta Jones, who's a perinatologist, addiction doctor. This is what they all use. It is the one that has pretty decent validity, still not as great as some of the others, but it's the one that's most commonly used this day and age, although there are a lot of other tools. But this is directed to just pregnancy. It's non-confrontational, and any single yes to any of these would warrant further discussion. In the first question, do your parents have problems with alcohol or drug use? So that's pretty not confrontational, because it's not even about them. It's their parents. And the reason this question is part of it is because, again, the 50% genetic inherited. This is just to kind of ease into the questions, if you will. Any of your peers. So if they're hanging out with people that are always at the bar, always using drugs, that could definitely be a higher risk. Now we're getting closer. Partner, does your partner use or abuse or have any issues? And then prior to pregnancy is important to ask, because some people are very good at, I'm pregnant, I don't drink anything. I'm pregnant. A lot of people can come back on their meth or their marijuana or whatever during pregnancy. But if they were using any of these substances before pregnancy, definitely a conversation you want to have, just as hormonal changes, the stress of pregnancy, There's so many changes that happen that, the stresses and how are they going to cope with different things. You just want to be open to having that conversation. You want them to be comfortable coming to you. And then, so far during their pregnancy, have you used any alcohol or other drugs? It's not uncommon for this one to be a yes. And a lot of people answer this yes because I didn't know I was pregnant and I was at the bar. Is something going to be wrong with my baby or what have you? So it's just very non confrontational, but at least can, again, start that discussion. Any questions? I need to take a drink of water. Darn COVID. I said I didn't put it in here. I am going to just quick mention, the tool we used to use was called the DIRE. The DIRE stood for distance. So diagnosis. What was their diagnosis for needing a chronic? So this DIRE was used more for people who are on chronic opioids. So people who are on pain meds for chronic pain or what have you. And so it broke it down into what was the diagnosis. Was this a diagnosis that had objective findings or not? What was the intractability of their pain? What was their response to other treatments that they may have tried? What was the E, Kurt? Do you remember the other?
Yeah. I'm not sure I remember. But
their environment they were in. And then we added the D to the end. So we made it DIRED. How is the distance? Patients were driving more than 30 miles to get to your clinic to get a pain medication. That's a pretty big red flag. Especially if they had to drive past other clinics to get to your clinic to get to pain medication, another big red flag. So, okay, so you find a person that you're a little bit more concerned about. You think it's beyond just kind of that brief intervention in clinic. Do they need some type of treatment? What kind of treatment do they need? Right now, it is still what you need to have in society is this Rule 25 assessment. This is gradually getting turned over to a chemical use assessment. Eventually, when it's a chemical use assessment, it can only be done by LADCs. Excuse me. Currently, Rule 25s can be done by LADCs or social workers. And so, again, it just kind of goes through a bunch of things we'll go through in a little bit. And what it does is it evaluates the person's level of risk, level of severity of their use disorder, and kind of helps match with where would the best place or best type of treatment be. So the questions that get asked, this is a long assessment. It can take an hour or more with patients. I'm not a huge fan, and a person comes in and needs treatment or asks for buprenorphine, for instance, or, is in withdrawal. You got to give them the meds first. You got to give them their Suboxone, stabilize the patient. We'll get a Rule 25 assessment eventually. Getting the Rule 25 assessment the second they walk in the door, yes, they're obviously going to flag very high for everything because they're in fentanyl withdrawal or what have you. But that's not going to save them. A Rule 25 assessment's not going to save them. Save their lives. And if anything, it's going to really annoy the patient. They don't feel good. That creates a lot of delays. The other thing in delaying this Rule 25 assessment until the patient is stabilized on their medications is it gives you a chance as their provider to build that relationship with them, build that positive recovery environment within your clinic, within your program. And then often, there's a handful of patients who, Kurt and I, in our experience, and some of you on here who have also been doing this for a while, you might not even need to send a patient into inpatient treatment because they're able to function. They're back to their jobs. And so I think sometimes giving the patient a moment to get out of, that crisis mode can really change a lot of things. So let's break these down a little bit. So Dimension 1, they look at their acute intoxication or their withdrawal potential. So this is obviously if they walk in and they're in florid withdrawal, they're going to score off the charts on this one. But if you've already stabilized them, it does look at their past history. What has it looked like in the past? What do their withdrawals looks like? If it's a person with alcohol use disorder, have they had withdrawal seizures? Obviously, that's going to be a person who is higher risk. So it doesn't just look at this immediate, it also looks back into their history of their substance, both intoxication and withdrawal. Dimension 2, biomedical conditions. So do they have diabetes? Do they have obesity? Do they have sleep apnea? Do they have other things? Do they have hepatitis C that they didn't even know about? Do they have HIV? So this is looking at the non substance use diagnoses that could potentially put them at higher risk. An insulin dependent diabetic might do better inpatient where they can have that a little bit closer management than doing it at home where they've been struggling. Dimension number 3, emotional, behavioral, cognitive. So mental health diagnoses. Often this can be a little bit confusing because you really shouldn't diagnose that bipolar, that depression, that anxiety, the schizophrenia, within that month of their last use. But at this point, you might not know what they looked like prior. So this is one of those, if they're very emotionally not stable, if they're having suicidal thoughts, if they're having homicidal thoughts, if they're having hallucinations or delusions, they're going to score a lot higher on this, which would potentially warrant a higher level of treatment. Dimension number 4, readiness to change. This is always very interesting to me. This is patients who come willingly into your program, patients who call you and want help. This is never a hard one to get, to score on. Patients who get arrested and they get forced into the Rule 25, obviously not always are as willing and ready to change. And so this can really be a big difference. A person who is still kind of in that pre-contemplative stage might warrant more of an inpatient or a more intense level of treatment because they might just not quite be there yet. And so having more of a structured environment may be more beneficial. Person who is super motivated, has lots going on in their lives that for whatever reason now was just the perfect time, might not need such a structured environment. And then what is their relapse potential? Are they living right now in a house with a whole bunch of other people environment that kind of comes up? But are they around a lot of people who are using? Have they relapsed and been to treatment a lot of times? What type of treatment have they been to? Have they been to 5 different outpatients or even intensive outpatient and just hasn't done well? Have they been to that many within the last year? That might be a person that scores higher and needs to go more of an inpatient. On the flip side, I have had a few patients who have lapsed and relapsed. I don't even know how many times, always went to inpatient, would get out, do well for a bit, and then lapse and relapse again. And so I actually argued this one once and I said, no, this patient needs to do outpatient, needs to do intensive outpatient because this patient needs to have those coping things built and have that treatment partner while they're also experiencing real life and the stressors that come up in daily life. And so sometimes as a provider, although I can't do this assessment, which is kind of funny to me still, I can definitely give feedback, and they will. Some assessors are a lot more willing to take kind of that extra add-on from a provider or somebody else with experience with this patient. And then dimension 6, what is their support system? Do they have a support system? Do they have access? Do they, are they homeless? Do they not have transportation? Do they not have insurance yet? Where are they living? Again, if you're living in a house where everybody is using and that is your support system, it's probably best for this person to go to an inpatient setting to kind of get eliminated from that setting. Those first 3 months when that frontal lobe and that decision making is still coming back, that's a high risk time to have to be challenging oneself in that environment. And so you get this Rule 25 assessment. The Rule 25 assessor says this is what you qualify. But what does that actually mean? There is a lot of different types of treatment Why they decided to break them down into like decimals, I don't really understand. I think over time they just started to add more types for make our board test that much harder. I don't know, but we'll kind of walk through some of these a little bit. Level 0.5, early intervention. Most people that are going to be at this stage don't actually get a level 20, rule 25 done. This is what you're going to see in your clinic. This is the person you're going to be worried about and want to help, but maybe you're thinking they have a great, environment. They have a very motivated support system. Doesn't necessarily need to go to a treatment, but maybe this is where you can get some of your motivational interviewing thing to kind of play in to maybe get to go to some meetings or more frequent follow-up visits within the clinic with yourself. Maybe find a sponsor, just someone to kind of help them through that. Level 1, this is outpatient. So they go to regularly scheduled meetings. It can vary. Usually it's about 3 structured meetings a night or a week. And sometimes these can last up to 3 hours. It can be like 4 to 7 p.m. They can have 9 to noon. But so it's very structured, but they're able to maintain their jobs. The people who have support systems, so they still are obviously going home. They're around their families. On top of this, usually the outpatient services encourage additional NA or AA or some other type of group meeting as well. But this is more structured. They do have their main counselor as well. So there is like a counselor and some type of facilitator at the outpatient treatment facilities. It's not just going to the AA meeting where it's kind of, the community. Level 2, intensive outpatient and partial hospitalization. I just put them under the blanket of level 2. So this is where you might need that mental health provider to kind of be involved. They can have medications that kind of get started, usually not Suboxone type products. Usually they'll continue these. They can do some of that medical management. Intensive outpatient, this can be 5 days a week. They have to go there. It's not full, 24/7. They're not living there, but it is pretty much all day. It's like going to treatment, but getting to go home at night. And so they do have a little bit more resources. They have more crisis services. Some places is really cool. They'll be associated with childcare places. So the mom goes in the morning or the dad goes in the morning or the aunt or the uncle or whatever, drops the kids off, does treatment throughout the day, almost like their job, and then goes home at night. Sometimes, and well, I'll leave that till the end actually. So level 3, you can see, is broken down into 4 different structures: clinically low intensive, high intensive, very high intensive, and then medically monitored. So what this means is the different type of inpatient place you might be sending a person to has different amounts of specialists. So there are inpatient facilities that don't have, mental health services right there, as far as like a psychiatrist or a psychiatric nurse practitioner, or they don't have a physician or a provider that can do your MAT. And so that can definitely vary in how much treatment they get. Some of these places will have places for their kids as well. So there's some treatment places that are welcome families to come and stay there with them. And so it can just definitely vary. People who need somewhere to go away to. So this is, I think, when we think about sending people to treatment, this is what we're all thinking in our minds. This is what I'm thinking in my mind. You're going to go away to treatment. You go live there. You're in a totally different environment. There are people there around the clock. They eat there. They sleep there. They have their meetings there. They have one-on-one time with therapists. They have one-on-one time with their counselor. They have group, all built in. And the level, the length of stay, in a perfect world, in my opinion, everybody would go for a 3-month stint at least to kind of get through that frontal lobe growing back up. But some of these are as few as a month, or a little as time as a month. Once we start getting to level 4, this is where it is more of like an inpatient dual diagnosis psychiatric and substance use. So this is almost impossible to find a place to send a patient. So this is your person who maybe really does have untreated schizophrenia. So they have, they have some hallucinations or, no insight at all that's even preceded the drug use or independent of drug use. And then they have the drug use on top of it. So they have physician meetings daily. They have a lot of stabilization there. And then they do the substance use on top of it. When I was in medical school and I did my psych rotation at Anoka, a regional treatment center, in my head, that was kind of the area of Anoka I was in. They didn't do a lot of substance use treatment then, and MAT was not really a thing anybody talked about. But some of the patients would leave and go to the methadone clinic and come back. And so part of that meeting with the physician or with the providers did talk about all that. They're not all locked facilities like you think of Anoka or St. Peter, but definitely a very high level of care. One thing I want to say about that is they're not 100% siloed. A person who goes to an inpatient or even one of these the medically managed level 4, when they leave or they get released or they get discharged, they will often, especially if they've been in an inpatient type setting, will go to an intensive outpatient afterwards or some type of an outpatient program afterwards. I think the level 0.5, your daily intervention things, that should be what we're all doing anyway as physicians, regardless of our specialty. You're always trying to be there for that patient to offer support and to assess. But especially when they're going from those higher levels, typically you want some type of a step down. Intensive outpatient, I also want to touch on, that's kind of where we think of sober houses a little bit. They don't do it. Not all of them will have some type of treatment built in, but some do. So, patients will get out of inpatient and then they'll maybe do an intensive outpatient, but stay at a sober house. So they have just even a little bit more structure. And even when they get out of the intensive outpatient and they're doing just outpatient in the evenings, they'll still be in that sober house. So they still have that supportive environment. This is especially true for people who going back home or going back to where they were is just really not a good idea. And so they're having to almost completely start over in a positive kind of living environment. So a couple of facts, and we've talked about these again before, but I just want to reiterate the third bullet point is what every addiction doctor likes to talk about, that only 10% of people who actually need substance use to treatment actually get it. And that doesn't always have to mean intensive inpatient, but any type of assistance and help. Women tend to, telescoping is a real thing. They tend to initiate substances later on life, and then they get more severe and they decompensate much faster, and they're much less likely to seek treatment. So especially if you're doing a lot of women's health in your practice, everybody should have screening, but these are the patients who are going to be a little bit harder to pull things out of. They're a little bit harder to get to go to treatment. Anecdotally, you start later, you're done having your kids, then you live in the stress of having 4 kids at home with COVID. Life happens. And, to go away to treatment just seems almost impossible. So it's definitely something to be aware of and supportive, just that women do start later. And then, we talked about this about a month ago when we did the mental health co-occurring with substance use disorder talk, but just the common co-occurrence. Patients with alcohol use disorder, how many have mental health diagnoses and or substance use disorders. Patients with non-alcohol substance use disorders, the high risks of all these other things. So nothing can be done in a bubble. Or in a silo, if you will. It all has to be kind of that fluid and work, it's a spectrum. Tobacco users, psychiatric diagnoses, we've talked about the schizophrenia thing. It's very, very high. I'm going to remind everybody, a patient who has schizophrenia who's smoking and is on their antipsychotics and stable, if you get them to stop smoking, you have to watch the dosing of their antipsychotics. Typically, you have to go down on the dose. That whole liver metabolism thing, that's annoying. Psychosis with cannabis, just definitely, again, things to be aware of. Higher risk patients. Treatment pearls. Treatment exists. Of course, we want to talk about the disease of addiction, but when you send a person to treatment, unless it's one of those very high intensive level 4 mental health, psych unit, substance use, they don't address detox or withdrawal. These are real things. Most, person comes into the ER, before you can send them to an inpatient psych bed even, you have to get the drug screen, and nobody will take them until they're through their withdrawal. And so this is where being able to do the MAT, MOUD is so important, because you want to be there for that patient. You want to be able to help them during their treatment, during that horrible time of their withdrawal and their detoxing. Detoxing can be fatal, especially when we're talking alcohol seizures. So it isn't all about getting somebody to go away to treatment. It's the whole thing. And then it's getting better, but not all treatment facilities do allow or offer MAT or MOUD. Personal experience, again, we usually get all of our patients started on their meds before we send them to treatment. And so that makes it a little easier, because we can make sure that wherever we're sending them will accept it. Some places will accept a person on it with the total purpose that they're going to totally taper them off when they're there. Not ideal. We've talked about the neurobiology so many times, and that's just definitely not an ideal thing. I think Kurt and I are doing a podcast coming up soon on tapering MAT and why that's not a good idea. And so it's just definitely important to know where you are sending your patients. Treatment doesn't happen immediately. I've talked on this, and that is okay. Not all of them address co-occurring. So this is where you want to have a really good social worker, a really good Rule 25 assessor, a really good county relationship, even if you don't have a social worker working right in your clinic. If you all want a list of awesome treatment facilities in our state that we know and love, let us know, because we have a list of these are our top favorites that we've had success with our patients at. Our patients come back and say, this is a great place. Our patients recommend it. So it's really knowing your patient, really knowing what they're going to need. A lot of sources. Oh, and then we have poll questions, and then I'll open it up to other questions. I don't know if, Kendra, you're going to, oh, nope, I have them right here. Oh, look at that. So I'm currently prescribing buprenorphine for opioid use disorder, yes or no, and the approximate number of patients you are treating, just a rough number. We're hoping soon in our new lives and new careers, starting very soon, we'll be able to take residents and students for an addiction / primary care kind of rotation combo in our addiction clinic and primary care combo.
Are you going to switch that?
Yeah. Can you see that?
It's still up.
Oh, stop sharing. I click share results, but I don't see them.
Can you close that and open the other one?
That is the other one.
It's doing that error thing that we experienced before, I think, because I don't know.
I shared it.
Yeah, it's okay.
Oh, that's all right. We'll let you know. All right. So here's us. Again, if you have any questions or anything, please let us know. Any questions on any of that talk?
Can I make a couple comments?
No. Yes.
So one of the things I just want to comment on, especially when we look at the levels of treatment and when you're looking at the 0.5, which is basically the people that you're going to see in your office. And I think both Heather and I have had many patients that come in who are clearly not in the throes of a heavy substance use disorder, but they're on the path. And I think that often the patient may not see what they're doing as a problem, right? Because of their experience. And for instance, we have a community near us where drinking 6 or 8 or 10 beers a day would be considered relatively normal. And so in their life, drinking 6 or 7 every night is not a problem. And so often it's the education that goes into that. When you see that younger person and they're drinking like that early on in their life, it's just the information that when you tell them that this is probably not a good way to do this, they don't, often they don't understand it. And I think, secondly, sometimes you're seeing people who are using substances to treat something else. The one that's in my head is a young college student who was smoking a lot of marijuana to help his anxiety. And in fact, his anxiety was getting worse, and his parents brought him in to talk to me. And when I told him to taper down and to taper off and see what happens, his anxiety went away. And so he was clearly smoking more and more and more and headed down the wrong path. When education just for him, understanding that this could have actually been his problem, often then we avoid those other levels of care. And so really interesting to have conversations early on.
Yeah, and I think it's, it's like anything when you're a student and you're learning how to even have these interview conversations, and they can be uncomfortable, and I don't know, to start initiating them. Kurt and I work with students and have them try to ask these questions. You want to be as comfortable and as non-judgmental, non-questioning as humanly possible. For me, when I always start well, how much you drinking, or what's your drink of choice? Okay, now I just totally normalize alcohol because I'm talking right about their favorite drink. So it's not even a huge deal. It's having those questions, and maybe not even have a formal assessment. Don't have them fill out a case. Don't have them fill out any of these things, but know them in your head. And then just part of your normal conversation, kind of work them in there, because you'll get a good assessment, they're drinking a case a day. Well, okay, red flag. They're under a lot of stress. Well, what kind of things do you do to kind of help de-stress? Well, I have a drink every day or 5. Will you exercise or anything? You can have these conversations without having to maybe do here's a survey I need to have you fill out so I can see if I need to send you to treatment. That's just not comfortable for people, I think. So
Yeah. I think too, I often think of this guy who came in and he said he had quit drinking, but he was having problems that were clearly associated with drinking. But he said he had quit drinking. I said, "Oh, really?" He says, "Yeah, I don't drink hard liquor anymore, just beer." And so for him, that was stopping drinking. And he clearly didn't understand, that there is no difference. And he said to me, "Well, you can't get drunk drinking beer. Everybody knows that." So again, getting the more information can sometimes be very helpful. And my nurse said, he said he didn't drink, but he did drink. He drank beer. So yeah, that can be a great step. The other thing I was going to comment on, Heather, is you talked about the difference between men and women and the telescoping women have. The other anecdotal thing I would have is it seems more often when I see men at the beginning, they're having consequences more often from their alcohol than women are. Women often aren't in trouble, whereas often when I see guys, they're coming in because their situation has caused them problems. And that's just anecdotally what I think I've noticed more often. So that was great, Heather.
Thanks.
All right, any other questions? Go ahead.
No, I was just saying, a couple of weeks you're doing more of a deep dive into the different types of MAT, MOUD. Oh yes, and then there's the slides there if y'all want those. And the survey, so you can get your CME. Look at all that good stuff. All right, well, if anybody has any further questions, comments, thoughts, whatever, please let us know. You know how to get a hold of us. Otherwise, we'll chat at you either tomorrow on the Wednesday Echo, otherwise in 2 weeks right here. Thanks.
Thanks, everybody. Have a good day.